We are now going to discuss some of the rheumatic and vasculitic disorders. The first one we're going to talk about is juvenile rheumatoid arthritis. It presents in a variety of ways. This is many times different factors can trigger it. For example, we know that there are infectious factors that can cause arthritis-like symptoms or syndromes, such as the Lyme arthritis. That's an infectious cause. For the most part, it's felt that juvenile rheumatoid arthritis is an autoimmune disease, and sometimes you need an external trigger. We do know that it's a chronic non-suppurative disease. It's an inflammation of the synovium, and you're going to have as characteristics of it joint effusions, destruction of the bone or the joint cartilage, and bony deformity. You can also have fusion at times. Clinically, look for morning stiffness. It gets better as the day goes along. Also look for remission and exacerbation. You have good days, you have bad days. These patients can also somewhat get kind of tired. They can have joint pain later on in the day. The joint can be warm. There'll be pain on motion. So some of these patients try not to move whatever joint that's painful, and that can cause atrophy of the muscles around that joint. But there is no real erythema noted around the joint. JRA is actually a clinical diagnosis, and so it needs to meet certain criteria. First of all, the age of onset is less than 16 years of age, and you must have arthritis or more than two of the following that are listed there, such as limited range of motion, tenderness or pain on motion, increased heat in one or more joints. Also, the time, the duration of symptoms is important. They have to last for at least 6 weeks. And you must, it's a diagnosis of exclusion, so you must eliminate or rule out other forms of arthritis. And typically, it presents, as it presents in the first 6 months, that's going to be the type of arthritis that you're going to have, because there's 3 different classifications. The way it presents in the first 6 months is how you're going to classify it. The differential diagnosis includes lupus. That's a big one because they have also arthritis. Dermatomyositis. And a lot of these things course with arthritis. Rheumatic fever, remember we discussed that, and we said that rheumatic fever, one of the characteristics of it, the major criteria, one of them is arthritis, and one of the minor criteria is arthralgia. So that's part of your differential diagnosis. The third stage of Lyme disease produces an arthritis, and so do lymphoproliferative diseases. In fact, about 1/4 of children with acute lymphoblastic leukemia will present with joint or bone pain and can be mistaken as having arthritis. That's their initial manifestation of their leukemia. We're going to divide it into 3 different kinds. There's what we call pauciarticular, polyarticular, and then there's systemic onset JRA. The pauciarticular is going to be less than 5 joints. It's usually in the lower extremity, but really doesn't affect the hip. And you're going to have the large joints, so like the knee, the ankle. These are bigger joints that are affected. The polyarticular is greater than or equal to 5 joints, and these tend to be the smaller joints. They can be the large joints, but they tend to be small joints in many of them. So that's going to be the ones like the joints of the hands and fingers. It resembles the adult arthritis. They can have cervical spine involvement with the polyarticular. And the last one is the systemic onset JRA. This one, they will have other signs and symptoms first and then start developing the joint symptoms. These patients can have like persistent fevers, fever of unknown origin. They can have rashes, and they can have other involvements such as hepatosplenomegaly and serositis. So this is a much more systemic type involvement initially. Here you have a patient that has juvenile rheumatoid arthritis, and you can see this is smaller joints of the hands, but look at that, this finger, this finger, this finger. So you're talking smaller joints, and you're talking many joints, so you would probably classify this first as the polyarticular type of juvenile rheumatoid arthritis. Also, hard to say because this patient may be right-handed or left-handed, hard to say, but the muscle here is not as well developed. This could be because the patient is right-handed, or it could be because he has pain, or she has pain in this area and therefore doesn't use it as much, and so you get atrophy of that muscle. Here is the characteristic rash. It's fairly nonspecific, actually, not characteristic. It's a fairly nonspecific rash that you see in JRA, sometimes this rash is worse with the fever, and it comes and goes with the fever. It kind of gets darker with the fevers, and it'll just be an evanescent. It comes and goes. This is systemic JRA. There is no best test for juvenile rheumatoid arthritis. It is a diagnosis of exclusion. You rule out other diseases, and you say, it has to be this. You will have some acute phase reactants that are increased, like sed rate and CRP. They can have anemia of chronic disease. The ANA may be positive. If it is, it's helpful, but it may be negative, and then it's not helpful. Okay? Usually that is going to be seen with the poly and the pauciarticular JRA. The rheumatoid factor is typically seen in the older child that has polyarticular disease. So there's really not one best diagnostic test. The management of JRA is to preserve joint function. So you want to have patients hopefully pain-free so they can move those joints and use them. You also want to have patients having physical therapy. Non-steroidals are the first choice in the management of JRA. Some patients progress to use chemotherapy with methotrexate. Corticosteroids have very few indications. They have great indications in lupus, but not so much in JRA. You can use them on certain occasions, such as overwhelming inflammation or systemic illness. And obviously, physical and occupational therapy is very important. If you don't use it, you lose it. So it's very important to keep working those joints. Patients with juvenile rheumatoid arthritis, some of them are at higher risk for ophthalmologic problems, and so they need a routine follow-up. They can have iridocyclitis. Here you have a nice table that categorizes them all. You can split them up into the poly, pauci, and systemic. The polyarticular may be rheumatoid factor positive. Again, you'll see this in older girls. You'll see the lesions in the hands and the wrist, and the prognosis is not good, particularly if they're RF positive, rheumatoid factor positive. The next one, they can be ANA positive. This is in younger girls. The prognosis is good for them. And they can be seronegative, meaning that they can be negative for ANA and rheumatoid factor, and then it's a variable prognosis. The pauciarticular, they can be ANA positive, and again, this is going to be in younger girls. These are the patients that are at higher risk for eye problems like iridocyclitis. They have a very good prognosis, however. If they have rheumatoid factor positive pauciarticular disease, they have a poorer prognosis. And then you can have the HLA-B27 positive, and this is what you're going to see in boys that have JRA. They will have a higher incidence of HLA-B27 antigen positive. Those are the patients that are at higher risk for the ankylosing spondylitis. The systemic can be poly or pauciarticular. The pauciarticular have a pretty good prognosis. The polyarticular do not.